Okay. We could stay about 3 days talking about all these things. But of course we have to choose. And so I try to focus on, I would say, on the lesion I met in my life. So I'm showing you all cases I met in my life, which is, I'm in general hospital, so these sort of lesions you could find also in your practice. And you say, okay, why ACC, why cholangiocarcinoma? Because I'm trying also to talk about the neglected brothers of ACC. We all about to talk about ACC in cirrhotic patients, but we also have some ACC. We are in non-cirrhotic livers. That means we do not expect to be an ACC. The new epidemia, NASH, non-alcoholic steatohepatitis. Sooner or later we will have a change. We are seeing less hepatitis from a C virus, but we are seeing much more hepatitis from a NASH. And we expect the ACC from NASH will grow up in the next years. We have to wait for them. Of course, you have fibrous ACC and clear cell carcinoma. So ACC non-cirrhotic liver usually is a large solitary mass with well-defined margins and the area of necrosis and the peripheral capsule. Necrosis in the peripheral capsule gives the most often a central scar appearance, which is not a typical scar like in FNH, but it's an area in the central part of which is has a different behavior than the rest of the liver. Alpha-fetoprotein is only in about 1/3 of the patients elevated, so it cannot help much. And as already Brancatelli said, that what Weston said was a transverse scar, probably is due to necrosis in the hemorrhage. So this was a young lady. She was 5 years old, and she arrived with a history of oral constructive resorption. So we made an ultrasound showed a lesion. We made MRI, and you can see inhomogeneous appearance on T2 with a central area, which has a different behavior. And in a dynamic phase, you can really very much appreciate that this central area. This looks like a scar. There is a wash in, there is a wash out, there is a capsule, and in the hepatobiliary phase was hypointense. But this was made with the multi-hands. So we supposed it was an adenoma. It was resected, and it was in hepatocarcinoma in a non-cirrhotic liver. And you can see here, this is the central scar, the inhomogeneous appearance, they are quite large lesions. Another girl, this is a 37 years old girl. She had no risk factors, no contractive absorption, and at ultrasound she had 2 hepatic lesions, one on the dome and one on the caudal part of the liver. So my approach when I have a liver from ultrasound, I always use a liver-specific MR contrast agent, and I prefer to use, when I don't know how he will behave, this lesion, a liver-specific with a very strong and robust dynamic phase, because I want to see how to behave in the arterial, in the venous, and in the distribution phase. I want to wait 5-6 minutes to see what happens. Then I take the hepatobiliary phase. So these 2 lesions, one not much restricted, with a hyper-enhancing, no washout, and in the hepatobiliary phase, most of the lesion is iso-intense, only some part are hypo-intense, but is in the central part. So this is one of the behavior of FNH. But in the fourth segment, there was this lesion which was completely different. And as you can see here again, we have a sort of central scar. The lesion is restricted, is slightly hyper-enhancing, there is washout, it is black in hepatobiliary phase. Once again, we did not expect it could be an ACC. We said adenoma, FNH adenoma. We know we can have in the same patient FNH and adenoma. It was resected due to the position. It was an ACC. And going back to see again, we can see the scar. And this will be the problem of the years to come, NASH. Because in USA, more than 80 million people are affected by non-alcoholic fatty liver disease. As with the new drugs, we are seeing a decrease in ACV cirrhosis, but we expect to increase the ACC in NASH. So the rest of the evidence show that the significant proportion of patients with non-alcoholic fatty liver disease and NASH progress to ACC in absence of cirrhosis. And this was a male, 69 years old. He had NASH at the histology of the liver. There was this lesion, which was once again was quietly inhomogeneous with a central hyperintense area, which progressively uptake contrast agents. This was made at about 5 minutes. That's why I say I want to see a robust dynamic phase, because I want to wait. I want to see immediately black. And was quite unusual, but the rest was very restricted. And you can see here, sometimes ACC in NASH, they can mimic benign hemangioma, progressive enhancement. But on T2, the signal was not an hemangioma, it was very restricted, it was resected, it was in ACC in a patient with NASH, non-cirrhotic liver. And if we go to fibrolamellar ACC, it's the counterpart we are used to study when we talk about FNH. So, because they are usually young patients, and is a large lesion, the alpha-fetoprotein does not much help us, usually is negative. And histologically, we observe a fibrolamellar band, which often coalesce to form a central scar. And it occurs in a non-cirrhotic liver, non-clear cess predominance. So the lesion is hypervascular, but inhomogeneously hypervascular. And when we do CT, in about 2/3 of the patients, we see calcification in the central scar, which is a fibrotic, so we see just coarse calcification in the desmoplastic reaction of the lesion. And as the scar is a fibrous tissue, it can uptake the contrast agents due to pooling. So after 3-5 minutes, it can uptake for even 10 minutes. So this is another typical sign of this lesion. Hemorrhage and necrosis are rarely found, and with liver-specific contrast agents, these tumors do not show enhancement at the hepatobiliary phase. So there was is a medium-aged female with a large lesion, as you can see here, inhomogeneous arterial enhancement, a washout, and the central part reduces due to the pooling of some contrast, but this was made only at the portal venous phase, and they did made an advanced phase imaging. This was another lady, 50 years old, with a huge mass. And you can see here, the central scar can be hyperintense, but sometimes it's hypointense. When the desmoplastic reaction is strong, the fibrosis looks dark on T2. So, this makes the difference between the scar on FNH, which usually is hyperintense on T2. And you can see here, there's a huge this is an advanced phase. You can see here, already we have the washout in this lesion, but in the central part, in the desmoplastic component, we see the retention of contrast agents inside. Okay. And this was made with Bopta. It was made in 2 hours. Looks how the scar now is bright. This is something completely different from EOB. You will never see a fibrotic scar hyperintense with EOB, but with the Bopta, it has a very strong a robust dynamic phase, the contrast after 2 hours can be still retained by the fibrotic component and gives signal as a hyperintense signal. This is a sign we have a huge desmoplastic reaction. And this was a fibrolamellar ACC. And the last brother of the neglected brothers of ACC is the primary cell carcinoma of the liver, which is a rare subtype of primary ACC, where we have more than 50% of neoplastic hepatocytes with abundant clear cytoplasm. Due to fat or glycogen, in most of these patients we have an elevated alpha-fetoprotein, mostly male, mean age 52 years old, and the imaging findings are not very different from ACC, so we have a wash-in, we have wash-out. In these patients, the pseudocapsule is more easily seen than in ACC. This was a young man, 20-year-old male, and this is only the largest one. He had the liver full of these lesions. This was the largest, and once again, you can see here the ACC, non-classical ACC, they tend to have a large part in the center of the lesions, which we can call scar, we can call someone in some else way, who does not enhance, and once again, you can see here, hyperintense, there's not clear washout in reality, and this is a hepatobiliary phase, and once again here, this is BOPTA inside the fibrotic and necrotic component of the ACC, which markedly appear hypointense, such as this satellite lesion. And histology was clear cell carcinoma of the liver. Just one word about cholangiocarcinoma. I apologize who talks about the later, because just to say, sometimes cholangiocarcinoma, when they are small, they can be atypical. So the message is never trust of small hypervascular lesions unless you are sure it is a benign lesion. These are usually less than 3 centimeters. They don't have much necrosis and stromal reaction, but they still have the desmoplastic reaction. That means these lesions are hypervascular and they do not wash out. The disease-free survival is better than conventional cholangiocarcinoma, but if you can see here, this was a lesion which is almost isointense on T2, hyperintensity 1, markedly hypervascular, no washout. So washout is important to make a correct diagnosis of a malignancy of a focal liver lesions, wash-in, washout, ACC, metastasis, but it is specific only in 2/3 of the cases. That means 1/3 of hypervascular malignant lesions, they do not show washout. And in the hepatobiliary phase, either with multi-ans, either with the OB, the lesion is hypointense because this is not hepatocytes. And now the so-called PEComa. What is PEComa? It's the acronym of a perivascular epithelioid cell tumor. I was surprised. I had a meeting with June with a Chinese radiologist, and they showed me a lot of PEComas. In reality, in my life, I just find a couple of times. But it was interesting because in this field, in this family, there are many different lesions. These are mesenchymal tumors composed by histologically and immunohistochemically from perivascular epithelioid cell. They develop around the vessel. And in this cell, we can have lipid. That's why, because angiomyolipoma is part of the PEComa family. The more rare epithelioid angiomyolipoma is part of the PEComa family, and other really rare clear cell sugar tumors, never heard in my life, or lymphangioliomyomatosis in the liver is part of the pecoma, and even other rarer tumors. So, but this is usually a large lesion. They are usually subcapsular. In most of the cases, they are benign. 70–80% are benign lesions. Mostly are female in the middle age. These lesions usually are hyperintense 21, hyperintense 22. If they have fat, you see them with in-outer phase, and they usually are hyperenhancing. So, 58 years old female, bright 22, high 21, in-outer phase. You see we have a signal drop. There is fat inside. The lesion is moderately hypervascular. There's no restriction. And of course, not being hepatocellular lesion, is not able to uptake the contrast agents in the hepatobiliary phase. But in outer phase, the so bright signal on T2, not restricted, allowed us to make a diagnosis which was confirmed by biopsy of angiomyolipoma, which is a part of the pecoma family. This lesion, this was a female with a sort of nightmare liver because it was plenty of lesions. But the most important was this one, bright on T2, moderately hyperintense on T2, hyperintense T1, restricted diffusion this way. And the enhancement was inhomogeneous with early washout and black on hepatobiliary phase. And I told you this was she was plenty of lesions. That's why it's important to have a contrast agents will help you to make a correct diagnosis of the hand, because she had another lesions here, another lesions here, another lesions here, and many other lesions. And so one that was the typical we were looking at. The other one was very slowly enhancing hemangiomas. Then she had one hypervascular lesion here. In the hepatobiliary phase, hemangioma do not uptake. This uptake, especially the periphery, so this was an FNH, and this was not. It was resected. It was an unspecified pecoma. At 3 years follow-up, the patient showed a new lesion, and once again, not much restricted, to be honest, but bright, very hyper-enhancing, no washout, but if you wait 5 minutes, there was a sort of washout, and it was black on the hepatobiliary phase, biopsy, pecoma. In the group of vascular tumors, we have two main lesions, hepatic epithelioid hemangioendothelioma, which usually are more frequently are multinodular disease. Typically, they are in the right liver lobe, periphery location, subcapsular. They tend to coalesce of multiple nodules and give capsular retraction. Sometimes in the desmoplastic component, we can see some coarse calcification, and the enhancement is inversely correlated with the desmoplastic component. So the lesion can be single, very rare, but when you see this target sign, think about epithelioid hemangioendothelioma. Typically right lobe, subcapsular, the enhancing rim, and the central desmoplastic component that you can see here. There's a different in the ADC map. We can see this target sign of this lesion. Very typical. It's quite unusual to see only one lesion. More often we see much more lesion. And once again, they are mostly located in the right lobe, they are mostly peripheral, they are mostly subcapsular, and they have a rim enhancement in the vital part. The central part is a desmoplastic component, and in about 30% of the cases we can see extra liver localization of this lesion. And this lesion can be resected if single, or go to orthotopic liver transplant, the only way to cure these lesions. The other lesions in the vascular group, which is important, is the angiosarcoma. is the most common primary mesenchymal tumor of the liver. Usually is mostly male in the late adulthood, about 50 to 60 years old. In about 10% of the cases, we can find some causative, the cause of these lesions, it is exposition to some chemicals, which can be the cause of the onset of this tumor. And we have 4 types of growth pattern. We can be multiple, a large dominant, a mixed pattern, so a large with a multiple satellite, or diffuse infiltrating micronodular tumor. As all the sarcomas, we can see necrotic and hemorrhagic changes. Whenever we see sarcoma, look for the hemorrhage, not only for angiosarcoma. The lesion is inhomogeneous, heterogeneous, with the central peripheral ring-shaped enhancement on arterial and portal face and progressive enhancement at the late face. So don't misdiagnose with the hemangioma, but with this large lesion, with the inhomogeneous appearance. We can see also some bright in unenhanced CT due to the presence of a small hemorrhage, and you can see this diffuse enhancement. Progressive is not a globular enhancement, and this was an angiosarcoma as a unique large lesion. But this patient, he worked in a naval center, and he was exposed to vinyl chloride monomer, and we see the liver completely substitute of this progressive enhancing lesions. Was an angiosarcoma. And the other sarcomas, whatever they are, you cannot make a correct diagnosis before, but whenever you see the hemorrhage and the large necrotic changes inside, think about a sarcoma. Huge hemorrhage inside this huge lesion, rhabdomyosarcoma. And finally, inflammatory pseudotumour, which is not really a tumor, is a benign lesion, is spontaneously resolved, and is considered to be a result of an exaggerated inflammatory response. And sometimes it's not easy to make a diagnosis, but when you can see something that will resemble a sort of an abscess, think about these lesions. He has no risk factor, he also has fever and fatigue. You can see a sort of net enhancement in the lesions. The few cases I've seen, I often see this sort of net enhancement inside, and you can see here after 2 months follow-up, the lesion is almost disappeared. Remember, this inflammatory pseudotumour can simulate a cholangiocarcinoma. Whenever you see a lesion spreading along the portal vessel, we shrink the biliary ducts. In this case, was a pseudotumour of the biliary tract. So in conclusion, in the liver we can find several different lesions. We can have rare events of ACC. Remember that cholangiocarcinoma can be hypervascular with no washout, so hepatobiliary phase is important. Mesenchymal tumors, the so-called pecomas, must be considered in case of large lesions with fat and weak enhancement. Angiosarcoma and other sarcoma, typically they show hemorrhage, and sometimes a correct diagnosis is not possible. Don't be shy and ask for a biopsy. Thank you very much.